Good morning, everyone. My name is István Baradács, and today I will present you my 6 months progress in my PhD topic, which is the targeted therapy in ovarian cancer. I'm a resident doctor at the Department of Obstetrics and Gynecology at the Semmelweis University. My two supervisors are Balázs Lindner and Ferenc Bánhidi. My vision is that the molecular targeted treatment could completely change oncological therapies, and my mission is behind my work is that to learn about the possibilities given by these targeted treatment and bring the knowledge back to the bedside. We have started to work on 3 different projects. The first one is the efficacy and safety of PARP inhibitor therapy for advanced ovarian cancer. The second one is investigating the efficacy and safety of VEGF plus PARP inhibitor combination therapy for ovarian cancer. And the third one is the HER2 positivity testing and scoring in high-risk endometrial cancer. Let me start with my first project, the efficacy and safety of PARP inhibitors in ovarian cancer. It's a systematic review and a meta-analysis. Let me give you some background information about ovarian cancer and this kind of treatment. Ovarian cancer is diagnosed in 75% of the cases at an advanced level, and relapse occurs in 70% of the cases. These facts highlight the need for a new effective therapy for this disease, and PARP inhibitors showed significant progression-free survival benefit in recent clinical trials. These kind of drugs can find the DNA single-strand breaks and facilitate the formation of DNA double-strand breaks. And this kind of therapy, as in most of the cases, is used as a maintenance treatment after the first line or second or third line chemotherapy treatment. And our aim is to assess the efficacy and safety of PARP inhibitor therapy for advanced ovarian cancer. Our clinical question is, do PARP inhibitors provide better progression-free survival in advanced ovarian cancer, or patients are diagnosed with advanced ovarian cancer? The intervention is PARP inhibitor therapy, the control is placebo, and our outcomes are progression-free survival, overall survival, and adverse events. Our hypothesis is that the PARP inhibitors provide better progression-free survival and are well tolerated for the patients. We ran our systematic search in the middle of October, and it resulted in 16 eligible full text for our meta-analysis. Let me continue with the results. The first outcome is the progression-free survival, defined by the time from randomization to disease progression or death. It's a frequently used outcome in oncological therapies. On this slide, it was investigated in the recurrent tumor type in the intention to treat population. The heterogeneity was 7%, and the pooled hazard ratio is 0.37. The meaning of this number is explained in this little green box. If the baseline risk for the intention to treat population to disease progression in 3 years is 80%, with a hazard ratio of 0.37, in the control group 80, in the intervention group 29.6 patients will have disease progression in 3 years. It's clinically and mathematically significant high hazard ratio benefit for the PARP inhibitor patients, and support the use of PARP inhibitors in this patient population. On the second slide, in the result, the progression-free survival, it was investigated in a newly diagnosed tumor type in a BRCA mutated patient population. The heterogeneity was 20%, and the pooled hazard ratio was 0.36. These results are also clinically and mathematically significant. The second outcome was overall survival. This is the gold standard measure of efficacy of oncological therapy in the clinical trials. It was investigated in a recurrent tumor type with BRCA mutated patients. The heterogeneity was 0%. The pooled hazard ratio was 0.71, and it's also significant clinical and mathematical benefits or different. And the third outcome were adverse events. Adverse events is the most important measure of tolerability in oncological therapies. On this forest plot, you can see the grade 3 and grade 4, so the serious adverse events in the newly diagnosed and recurrent tumor type. And the heterogeneity was 97 and 87. And the pooled risk ratio was 2.34. These data shows us that the PARP inhibitors raises the number of adverse events, but it's not a surprising result, because, as I said, the PARP inhibitors are used as maintenance therapy. So it's an added therapy for the chemotherapy, on top of the chemotherapy. As we arrive to the summary part, I will introduce the strengths and limitations for our meta-analysis. Our meta is based on randomized clinical trials only. The risk of bias was low, and we have new results in clinically important subgroups. On the other hand, there was limitations, minor differences in intervention was seen, and in some cases the overall survival data was not available, and in most of the studies the follow-up time was short. In the daily-based clinical practice, PARP inhibitors could be used for treatment of BRCA-mutated patients, and they also showed significant benefit in newly diagnosed tumor type and these population. Treatment interruption is not needed in a real-world therapy, because these adverse events was handleable with a dose reduction, and the therapy could be finished with this, and interruption and discontinuation wasn't required. We have to point out that randomized clinical trials with BRCA wild-type patient is needed, and it's not questionable that the longer follow-up time is required to have more significant and more evidence-based data. So the final conclusion is that the survival benefit was seen in the PARP inhibitor treatment with a longer progression-free and overall survival, especially in well-selected patients with genetical mutation. In the term of tolerability, the number of adverse events was increased, as we expected it. In the majority of the high-grade adverse events, the therapy could be continued with dose modifications, and no treatment interruption and discontinuation was required. And finally, the PARP inhibitor therapy is well tolerated. Our second project is investigating the efficacy and safety of PARP inhibitor plus VEGF combination therapy for the treatment of ovarian cancer. The background is kind of the same for this meta-analysis. The ovarian cancer is characterized by late diagnosis and high relapse rate. There are limiting factors for patients to have plenty of lines in platinum-based therapy, such as myelosuppression. These combination could help the opportunity to have chemotherapy-free treatment for our future patients. And these two drugs are have a more effective clinical benefit with together. Our aim is to assess the efficacy and safety of VEGF plus PARP inhibitor therapy in ovarian cancer. The clinical question is, do the combination therapy provide better progression-free survival for our ovarian cancer patients? The intervention is the combination therapy. The control is PARP inhibitor alone. The outcomes are progression-free survival, overall survival, and adverse events. Thank you for your attention.
First question. Very nice study. You showed actually small heterogeneity in the overall survival. Still, you had two studies which were actually significant itself, and one study which was not. And actually in that one, the range was very wide, I mean the prediction range. So, I mean, two questions. That one is that, is there differences between, I mean, are there different PARP inhibitors, and is there a difference in their efficacy? And if this is not the kind of the reason, that what could be the reason that actually one is absolutely just no effect and the other two has an effect?
Yes, so thank you for your question. The answer for the first question is that between the different PARP inhibitors therapy, big differences in ovarian cancer treatment wasn't seen in the aspect of progression-free survival or overall survival, but these therapeutic lines were a bit different, and as I said, there was a short follow-up time to calculate a real important data of overall survival, because in the different studies the follow-up time was differ from 24 months to 72 months, and it's a huge difference, and maybe overall survival shouldn't be calculated from such a short period of follow-up time.
Thank you very much. It was an amazing presentation, of course, and I think for all of the others, you said the quality high. Actually, I have a question regarding your first study.
Yes.
I don't remember whether we discussed this during the group meetings. Did you check the sponsorship bias and the publication bias in the studies? And going further, the other part of my question is, if these studies were sponsored by pharmaceutical companies, are there any ongoing real-life studies?
Yes, thank you for your question. Most of these, you have to see that these kind of studies are sponsored with millions of euros with different pharmaco companies, but these are multicentric and international randomized clinical trials, and we only investigating them. But there are plenty of real-world investigation and real-world trial in this kind of treatment, because the PARP inhibitor therapy is in the guideline for the recurrent tumor type in the, after the third line of chemotherapy as a maintenance therapy.